welcoming everyone to this symposium. We are very curious to also learn more about you. We would like to know more about who you are here as an audience. What I would like you to do is go to www.menti.com. So please go to www.menti.com and use a code to answer a few questions. And the code is 92545204. And we have 3 questions for you. And if for any reason Mentimeter is not working, that's no problem. Please feel free to answer the questions in the chat directly. I will also be able to see this. The first questions, we're really curious to find out where you're joining it for us from today. So I see a few people are saying hi. So hello to you too. Welcome here. A few people like myself are joining from the Netherlands. I see Utrecht. I see someone joining us from Côte d'Ivoire, Abidjan, from the United States, from Tennessee. I know the majority of you are from Ghana. I hope also people who are joining us through Ghana are finding their way to Mentimeter. And I see a few comments in the chat already. Feel invited to also tell us where you're from in the chat. The code is, if you want to join Mentimeter, Brechtje de Kok, I see your question. It's 92545204. So I see someone is joining us from Detroit, Michigan. Mabel joins us from Ghana. Someone from India. Andrews, welcome. I see you joined from Ghana. Najat from Ghana. So we are an international community here right now. 15 of you have found your way to the Mentimeter. Let's give it a little bit more time. Someone from South Sudan. Welcome, Gideon. Bernadette from Ghana, welcome. Eunice, welcome. Mavis. It's so good to see so many of you. Someone from Tamale, all the way up north in Ghana. Someone from Amherst in the US. So a very international audience. Thank you. Our next question to get to know you a little bit better is, what drives your interest in hypertensive disorders in pregnancy? Are you a health professional, a researcher, a policymaker, a survivor or family member, or other? And please let us know in the chat. So Isabella from APEC Ghana is a researcher. She will be introducing herself perhaps more later today. See many health professionals joining us, also many researchers. You feel invited to also answer this question in the chat. Many health professionals, and if you're a health professional, are you a midwife, a gynecologist? We also have a genetics researcher, Claire Simpson, many midwives. Welcome. A clinical pharmacist, nutrition officer, occupational health specialist. So we are with a very diverse group of people. And this also means that we really invite you to ask questions and add your expertise to today's talks. Welcome. I will be moving to the next question. And we're also really curious to learn more about what you hope to learn from today's conference. And again, feel free to type this into the chat or use the Mentimeter to provide us with an answer. The organizing committee has tried to create a very diverse program. But we will be using your aspirations of what you want to learn about these sessions also for the planning of future sessions. And there are also a number of speakers already present here who can also take with them your hopes into their talks. So I see the first person already answer this, what hopes to learn: management, effective prevention, new ideas, advocacy, to update my knowledge. And in the chat, I also see some longer answers, which is great because it tells us even more. To update new treatments, modalities. Well, the talk by Dr. Bayu will be really interesting for you because he will be talking about the latest insights about magnesium sulfate treatment management approaches. To update, increase maternal newborn survival. We have a session on how to provide evidence-based care for prematurely born infants. updates and management. Fantastic. Okay, thank you very much for all these answers. Because of the time, I will yield the floor back. I will stop sharing my screen, but we will make these slides also available for you afterwards. Gina, could you pull up the general presentation again? And in the meantime, please keep your interests and hopes and coming in the chat, because we will be reading along.
Thank you everyone for joining us, and it's a pleasure to have you at the third scientific conference. And this is the program outline. We'll start with the plenary opening, and we'll have a welcome address from the chairperson. The guest speaker will give a presentation. We'll also listen to survivors as they share their stories of hope with us. And then we'll also have a panel discussion. We'll have a music interlude. After that, we'll go into the parallel sessions, which will be breakout rooms. So we'll have the main room and 2 breakout rooms. And we'll also come back after the parallel sessions for another short interlude, and we'll go again for the second breakout rooms. And finally, we'll have the plenary closing, which will include the key messages, another story of hope, and we'll just take you through some of the things that APEC Ghana does. Next slide, please. So at this point, we are going to listen to some messages of solidarity from our partner organizations. We have the first message from Dr. Marcus Green on behalf of APEC-UK, and we'll also listen to Kimber MacGibbon on behalf of Hypertensive Education and Research Foundation. So we are going to watch the video from Dr. Marcus Green.
Good afternoon. My name is Marcus Green. I'm the Chief Executive of Action on Pre-Eclampsia. We are the charity which does very similar work to you, only in the United Kingdom, and we've been doing it for the last 29 years. I remember about 3 years ago, Koiwah got in touch with me and wanted to talk about what we were doing, wanted to learn more, and wanted to find out how we had made a success of Action on Pre-Eclampsia in the United Kingdom. I remember that conversation well because Koiwah absorbed everything I said. She was insightful, lots and lots of questions, and went away to start thinking about what APEC in Ghana could look like. Here we are 3 years, 4 years later, and you are having your third scientific meeting, where I understand that you are looking particularly at patient safety and the quality of care. This couldn't be more appropriate at this particular moment, and I'm delighted that you are concentrating on quality of care, because without that, we're all in trouble. Now, I recognise that the work that you have been doing is very different to the work that we do in the United Kingdom, but it isn't without its parallels. You have done a tremendous job over the last 3 years in raising awareness of pre-eclampsia, a condition which Koiwah tells me was barely known amongst the public 3 years ago. So I congratulate you on that. You really are doing an exceptional job. This conference today is so important in spreading awareness and making sure that people understand what it is that pre-eclampsia is, what hypertensive disorders of pregnancy are, what HELP syndrome is, and how we can combat those. Because, like you, we don't have all the answers. There is no magic bullet to cure pre-eclampsia, but a series of good initiatives, good care, good observations, women knowing what to look out for are the difference between a successful pregnancy and a traumatic experience. You are doing wonderful work over in Ghana, and it was a pleasure a few years ago when I met with Dr. Buckman when he was in the United Kingdom. And I hope that his work and the work with so many of you other scientists is going to make such a difference to care of women and care of families who are affected by pre-eclampsia. In the UK, we do 3 things principally. The first of all is, like you, providing support to women, answering those questions that we hear the whole time. Am I going to get pre-eclampsia again? Is it caused by my lifestyle? Is it caused by something else? We hear from women on a daily basis who feel that they do not have all the information that they need, and so we do our best to provide them with that information. The second thing that we do is we run a course on preeclampsia, what it is, how it can be identified, and what the best ways of treating it are. This is designed for midwives and doctors, and anybody who wishes to can register at apec.org and they can take part in it, and it's a useful, worthwhile course. The final thing that we do is putting the pieces of the jigsaw together. We do this through the research that we're involved in. We're currently involved in around 20 research projects across the United Kingdom and into other parts of the world as well. These research projects mean that we're finding those little pieces of the jigsaw, and we're also, equally as importantly, finding those which aren't parts of the jigsaw. But we do know that good observations, good care, checking urine, checking blood pressure are the basic tenets wherever you are. You've done an incredible job in Ghana. You're raising awareness, you've managed to get some great influence, and you're doing a fantastic thing. This conference today is just one part of that, and you should be very pleased with what you're achieving. I hope it goes terribly well. I hope it's a rip-roaring success, and we in the United Kingdom stand ready to help in any way that we can to help you with preeclampsia. Thank you very much.
Okay. Hello, I'm Kimber MacGibbon. I'm the Executive Director and co-founder of the Hyperemesis Education and Research Foundation. We're the leading organization for research, advocacy, and education on the pregnancy condition Hyperemesis gravidarum, or HG. And we're very excited to partner with Action on Preeclampsia Ghana to speak with all of you today. We've been helping women for 2 decades around the globe, and there is a great need for training of healthcare professionals on the assessment and treatment of HG in Africa, as well as general public education, so mothers know when they have more than morning sickness and need to get help, and their community knows how to support them. Women with hyperemesis suffer from weight loss, malnutrition, dehydration, and debility as a result of severe nausea and vomiting in pregnancy. HG predisposes women to many complications, including preeclampsia, fetal loss, hemorrhage, embolism, Wernicke's encephalopathy, organ failure, premature delivery, and growth-restricted babies. Further, 1 in 3 babies will not make it to term. Children exposed to HG may suffer additional complications such as neurodevelopmental delays, mental health issues, and cardiometabolic issues later in life. Our research finds that women who receive medication for HG have more live births and better maternal and fetal outcomes. Our research has found that the genetic links to HG, specifically GDF15 and IGF-BP7, are both involved in placental formation, appetite, and cachexia. So women have increases in these hormones and then have symptoms such as nausea, vomiting, anorexia, muscle wasting, loss of appetite, and food aversions. And this is exactly what we see in HG. Too many moms for so long have been told that this is a psychological disorder, or women feel stigmatized by this and don't feel they want to get care for this, or they should not receive care for this, and they feel like it's normal. And we see this in so many countries, especially in African women, and we're very concerned about this. It is unknown how many women actually suffer from HG each year, but we know that studies have found up to 10.7% of women in various populations experience HG. And one study from Nigeria recently reported about half of women in their clinic had HG. This is very concerning to us. Lack of consistent diagnostic criteria and recognition likely results in underreporting and lack of treatment for many women. So we believe that more research is needed into the incidence of HG among African women and what factors may reduce these numbers. The concerns we have are that mothers that have prolonged HG, the ones don't get very good treatment and have symptoms beyond 20 weeks or halfway through their pregnancy, are twice as likely to develop preeclampsia, and they're more likely to experience eclamptic seizures. So treating HG more effectively can reduce the length of time a mother has nausea and vomiting and or the severity of her symptoms. This in turn reduces the number of women having secondary complications, particularly preeclampsia, which we see very often, even here in the United States, where we work with women every day all over the world and find so many women do not get the care they need and end up with multiple complications. Because of this, because of these many often preventable complications of HG, HER launched the collaborative campaign called One Mom is Too Many to change the narrative about HG from a focus on managing nausea and vomiting in pregnancy to preventing the severe symptoms that lead to complications such as preeclampsia. By reducing the rate of the severe symptoms, we believe we can reduce the incidence of preeclampsia in Ghana. Thus, we are partnering with Action on Preeclampsia Ghana to provide innovative tools and resources which we've developed over the last 2 decades to help them develop new guidelines and research and management of HG in Ghana. We have several goals. We're going to look forward to working with them on researching the incidence and management of HG, identifying women with HG and those at risk of preeclampsia, developing treatment guidelines that reduce severe nausea and vomiting in pregnancy, improving maternal nutrition, and educating health providers and the public on the management of HG. And we ultimately want to give women and their children a chance at a healthy future in Ghana. We're very excited to partner with Preeclampsia Ghana, and we believe that one mom is too many to experience preeclampsia. So we are looking forward to working with you to reduce maternal health complications like preeclampsia, and we really appreciate this honor of getting to speak with you today and share about HG.
Thank you for sharing, Kimber. We will now move to the next point of the agenda, which is sharing a story, patient survivor story. If you could please go back to the previous slide, Gina. Yes, thank you. Stories of hope. And I will share my screen. It's a story of someone who was already introduced just now, Koi-Larbi.
Preeclampsia kills more women than any other maternal health complication. Accra also records the highest number of maternal deaths in Ghana. That's according to the immediate past Regional Health Director, Dr. Linda Van Otu.
They go into deliver with very high blood pressure level. Some of them, when they are pregnant, before they became pregnant, they did not have blood pressure or hypertension. But through the pregnancy, you find that the blood pressure goes very high. So high that some of them can even faint. And then some of them, unfortunately, die. And once the baby is inside, when this happens, then the mother loses her life and the baby also loses his or her life. We have had blood pressure readings that are unimaginable.
Like?
One of them went to as high as 300, over 180. And that is unimaginable.
Koiwah Koi-Larbi of Osuapia survived this. She lives here in Accra with her husband and their only child. But for preeclampsia, she should have been a mother of 3 by now. She narrowly escaped death twice.
I had attended antenatal for 27 good weeks, a whole first degree holder. I was as ignorant as anybody else. Even my mom, who had it, couldn't, for whatever reasons, didn't tell me, even though I knew she had lost some babies. The nurses or whoever who saw whatever sign, because it just didn't start that night. I had the symptoms, headaches, you get big unnecessarily, but nobody said anything. And so it's ignorance that killed my baby. I'm lucky to have survived eclampsia because it affects the brain. It just, some people just don't survive. And when they do, they are like nothing, robots.
Yes, she survived the first one, but the baby did not. She conceived again in 2013.
This time I did my antenatal care for 6 months only in Ghana. And then I went to the States. Whilst I was doing antenatal here, I didn't get any symptom of preeclampsia. But when I got to the States, at 34 weeks, the symptoms started. But you see the difference there for whatever they did. They managed me until I was 38 weeks and then delivered to me a safe baby girl who is healthy today and is about 4 years. And I returned home, no complications.
According to the Journal of Obstetrics and Gynecology of India, the risk that a woman in a developing country will die of preeclampsia or eclampsia is about 300 times that of a woman in a developed country. It appears the story of Koiwah confirms this research because there was a repeat in Ghana in 2017.
One Saturday, I was just extremely tired. It was very unusual. And because of my history, we're always checking our pressure. So my husband was like, we should go and check my pressure at the hospital. We got there and my pressure was 150/100. The GP said he has to detain me. I was like, oh, GP, you give me the antihypertensive drug. I'll take it tomorrow morning. I'll come. Then he called the specialist and he said he should detain me. I was there for 4 days. They were doing the routine, checking fetal heartbeat, you know, advising you to do kick counts and all that. And then on the 5th day, in the morning, the night nurse comes to check fetal heartbeat. Nothing. Matron comes around 11 o'clock, checks again, no beat. Then they call the doctor who comes in around 2 p.m., confirms with the scan and says, I'm sorry, but we lost him. So this time the baby did not even come out. He died in my room.
Because of her previous surgeries inducing her to have natural delivery didn't work, so she had to be cut again to remove a dead fetus out of her stomach. It is very rare for pregnant women to survive this because of how it strikes. Dr. Linda Vanotu again.
Now let's come back to how bad is it in the Greater Accra region?
Yes, in the Greater Accra region, over the past 4 years, we measure maternal mortality in terms of 100,000 live births. So if we had 100,000 women delivering live birth babies, they look at how many of them died or would probably die. In the Greater Accra region, it's about 200 per 100,000 live births. But over the years, it is going down gradually. Gradually, it is going down. If you look at the absolute numbers, we find that there is some reduction. And if we have more women delivering, then even if we have, let's say last year we had 200, and this year we have 200, but last year 100,000 women delivered, then you have 200 per 100,000 live births. That's if they had 100,000 live births. If this year we still have 200 women unfortunately losing their lives, but we had 250 or 150,000 women delivering, then you see that the ratio would go down. So in the Greater Accra region, I would say that we still have to reduce our maternal mortality because we are not happy with the numbers that we see. As at the end of the third quarter, 2017, we have recorded 152 maternal deaths. Yes, absolute numbers. But you see, we have big facilities here, and the places that we have a lot of these deaths occurring are the facilities that are big, because they will receive referrals from the smaller facilities where they cannot do some interventions that can be done in these big facilities. So if you look at the region, you find that the metro, we have Ridge Hospital here, we have Koiwah here. And these two facilities alone receive a lot of clients. We have 37, we have police hospital. We have other facilities like the Chimota and the rest. So these facilities within the metro receive a lot of cases from even outside the Greater Accra region. But for me, whether it is coming from outside Greater Accra region or not, doesn't matter. What matters is that these are women who need more care than wherever they were could offer. So it is important. You understand? If you look at the region again, the
full video will be posted on the chat if you want to continue and see the rest.
Hey, hello everyone. I'm Dorothea, as has been introduced already, and I'm here to introduce the chairperson for the occasion, and I'm very happy about this. Our chair for today is a public health physician and clinical epidemiologist with research expertise in reproductive health, malaria, and non-communicable diseases. She holds both PhD and MSc in clinical epidemiology from the University of Beatrice in Netherlands. and also an MPH from the University of Ghana. She is a very passionate person about capacity building and training of the next generation health service delivery and research workforce to address persistent context-specific challenges, such as what we are going to discuss today. So once again, it's my pleasure to introduce Dr. Mrs. Mary Coleman as our chair for today. She is currently a research fellow with the Department of Epidemiology at the Noguchi Memorial Institute for Medical Research, a part-time faculty at the University of Ghana Medical School and the Ghana College of Physicians and Surgeons. She is a president-elect of the Medical Women Association of Ghana. And Dr. Mary Coleman is also a member of our very own Sports Impact Study. So she is going to be our chair for today. But before I hand over to Dr. Mary Coleman to give her remarks, I also like to introduce our keynote speaker for today. He's in the person of Dr. Fofie. He's a consultant obstetrician and gynecologist at the Family Health Division of the Ghana Health Service. So he worked both at the Greater Accra Regional Hospital and the Upper West Regional Hospital here in Ghana. At the Upper West Regional Hospital, he served as the head of the Department of Obstetrics and Gynecology, also as a Deputy Director of Healthcare, and also as Chairman of the Regional Maternal Mortality Auditing Committee. Dr. Fofie had his medical training in Cuba, an MPH from Sheffield Hallam University in the UK, and has a number of certifications from institutions, a number of institutions in Ghana, Geneva, and Korea. Worthy of note is that in 2008, Dr. Chris Fofie received the UNFPA Citation for Honors Award for his service to mankind. We'll hear his very insightful message, but before that, I'll hand over to our chairperson, Dr. Mary Coleman, to give her remarks. Thank you very much.
Thank you very much, Dorothea, for those kind words. Hello.
Hello.
Okay, great. Good evening to everybody. It's a pleasure to be here. I want to say a very big thank you to APEC Ghana and all the stakeholders who helped to put together this wonderful conference. I'm enjoying myself already, and I know I'm in the right place. I have very good hopes for this evening, and I'm sure that those hopes will translate into the Ghanaian woman. I want to believe that this conference offers opportunity to improve quality of care to women in Ghana. And as we deliberate this evening, we would be able to find some probably new ways of consistently providing this hope of quality of care to Ghanaian women, especially those who have hypertensive disorders in pregnancy. Quality of care is very important. It's a very important topic in our healthcare delivery, especially when it comes to maternal health in a country where maternal mortality ratio ranges over 300 per 100,000 live births. After big global initiatives like the Millennium Development Goals and then currently the Sustainable Development Goals, which we are working at. Maternal morbidities and mortalities continue to be a burden for our part of the world due to a combination of factors that tell on the quality of care available to our women. These range from the socioeconomic background of our women, maternal health promotive services such as family planning, availability and access to well-equipped health facilities in terms of infrastructure, equipment, and logistics, including essential medicines and blood transfusion services, amongst others. Unfortunately, we still have the 3 delays, which is in making decisions to seek care financially and really geographical access to care, and then being attended to at the point of care. These delays continue to contribute to poor outcomes for our women. Hypertensive disorders in pregnancy contribute largely to our maternal morbidities, our near misses, and deaths. Many women simply do not know what hypertensive disorders are, what the disease is, what predisposes one to it, what the danger signs are, what is required of them as women in the care process, what they can expect from their healthcare providers to make sure they get good outcomes. A lot of our women have no knowledge about these. Some actually live with myths about these disease conditions. And even those who know about them do not know how much or what services are available to help them. And we just heard Koiwah's story. Providers of care, and these include doctors, midwives, community health workers, have been trained, and we continue to train them as skilled workers to deliver good obstetric outcomes. The health system continues to improve in service delivery, including emergency obstetric and newborn care, referral systems, including provision of effective transport system using well-equipped national ambulances, health education, and promotive services, etc. Other stakeholders are also doing their part, like APEC Ghana, which continues to create awareness, engage stakeholders, and advocate for better care for women with hypertensive disorders in pregnancy. So there is a lot of hope for the Ghanaian pregnant woman, but still a lot of room for improvement. And this evening, as we go through this session, I believe that at least I'm looking forward to receiving more insights. And I believe that over or almost 200 participants who have joined us are also looking forward to that. Some insights into how our panelists will guide us to look at ways in which we can improve the opportunity for quality of care for the Ghanaian pregnant woman. I believe we will have fruitful deliberations and recommendations coming out of this conference. So I gladly accept to chair the session. And once again, I thank you all for the attention. Thank you.
Thank you very much, Dr. Mary Coleman. That was a very good opening remark, and we are glad to have you here with us. Thank you for honoring our invitation. And to all the participants joining us, we say a big welcome to you. Thank you very much for joining us this evening and or this afternoon, wherever you are joining us from, and we hope to have a very good session. Thank you. So at this point, we will have our guest speaker, Dr. Chris Fofie, who is the head of the Safe Motherhood Program at the Ghana Health Service, to speak to us on the topic, Hypertensive Disorders of Pregnancy, the Ghanaian Situation and Progress. Dr. Fofie, over to you.
Good afternoon. Thank you very much for the opportunity. At this point, can I share the slides? Thank you. All right, so it's a huge opportunity to be here today to share with all of you a topic that is quite dear to our hearts. We're talking about hypertensive diseases in pregnancy and the situation in Ghana. So to start with, as a quick outline, we'll be looking at, first of all, hypertensive diseases. We look at some important data from the field to look at some of the recommendations for the nation Ghana. So we look ahead. First of all, as introduction, I'll start by telling all of us that hypertensive complicate about 10% of all pregnancies. That if you take about 900,000 expected pregnancies in Ghana, then you can estimate the burden of the condition that we have in our country. And it will be important to put in measures to be able to cover up all these cases that we have. Again, the next thing to say importantly is that moderate and even very severe forms of hypertensive. That is very important because through that, most of our women hardly recognize any problem with hypertension until we get to very severe complications. In our traditional setup, we tend to associate disease condition with pain. So any disease that doesn't come with some level of pain or immobility, we hardly disregard it and we think we are healthy. So that really is one thing that affects hypertensive diseases in pregnancy. We're also saying that there is a need for quite a number of equipment to be able to really make the appropriate diagnosis, and that makes it very difficult for us at the point of entry, that is at the most of our clinic, to be able to do the necessary checks that are required to be able to do the early diagnosis. However, what we know is that early diagnosis at the end is quite important because that is what saves life. So we go further. Let's look at a bit of some of the results that we have from the field. The EMOC survey is an international survey led by Ghana Health Service and supported hugely by partners within the health space. And usually the last time was done in 2010, the most recent 2020, and across board about 107,703 facilities were reviewed. And here we're talking about facilities that conducted more than 4 deliveries within a month. So the results that were tabulated from there have been analyzed and are ready to be shared, part of it. And today I'll be giving you a gist of it. So looking at it, what we came out with, first of all, is that severe pre-eclampsia, eclampsia, for this 2020 EMOC survey accounted for about 13% of all the complications, and however was responsible for 22% of all the deaths. So if you take all the complications of direct obstetric complications that were recorded, 13% were attributable to hypertension.
Okay, so the connection has frozen while he's trying to get the connection back. And in the meantime, if anyone has a question or a comment he or she would like to share, you're very welcome to do so.
Thank you very much. I'm really sorry about the internet connection. So just go quick to just recover a bit of the time. So I was just trying to give a gist about the pre-eclampsia prevalence within the country in terms of complications that we get. And I just fell short saying that we have about 13% in terms of direct obstetric complications and 22% in terms of maternal mortality attributable to pre-eclampsia. Then we go further to look at, we say most of the facilities occurred in hospital, that's big facilities rather than the very small ones. And that has a very strategic importance we'll be discussing later. Again, we say out of the 1,703 facilities that were surveyed, only 31%, that is, that use the drug of choice for preventing eclampsia, that is magnesium sulfate or any anticonvulsant at all, which is very important. We should be using up to 100%. And here we have the entire country within the last 3 months preceding the survey, only 31% had used any form of parenteral anticonvulsant that's serious. Then we have 4% of the facilities still using diazepam as the only drug to combat preeclampsia, which is way out of what we expect to happen. So that is serious, and we want to change that. Next slide, please. So here I want us to look at this table that gives us a bit of the direct obstetric death, but first we just focus our eyes on the severe preeclampsia, eclampsia, where we have 12,704 as the complications that were gathered within the 1 year period. Whereas when it comes to deaths that were attributable to severe preeclampsia, we have 197. So that gives us a case fatality rate of 1.3, which is quite high. Let's move to the next slide, please. So as we speak now, preeclampsia, eclampsia is the #1 cause of death in the country, has surpassed hemorrhage as it used to be. So with this slide, what I intend to do is to look at where do we get, from which facilities or in which area do we get these deaths occurring. So clearly you could see here, we're looking at the entire direct obstetric deaths, and they are occurring more in hospitals, district hospitals, that's teaching hospitals, district hospitals. But when we get to smaller facilities, the deaths tend to reduce. And it's the same pattern with hypertensive diseases, where the deaths are much higher within the bigger hospitals. This has a big significance because the lower facilities have virtually no capacity to manage or first detect hypertensive diseases, and therefore they only present to them with very severe complications which they don't have capacity to manage, and therefore tend to refer them to higher facilities where they end up doing very poorly. Next slide, please. So going further, we look at the use of parenteral anticonvulsant. And here we want to know where the 31% that we described that had used parenteral anticonvulsant, in which facilities are they, which strata of our health care delivery. And when we look further, we see teaching hospitals had quite a high percentage, 100. But the striking thing is when you look at maternity homes and clinics. Maternity homes, only 15% had used anticonvulsant within the preceding 3 months, which is serious, because most of the deliveries occur at this level together with other clinics, and it stands to show that women that are routed through this path are likely and have preeclampsia are likely to receive poor quality care, and they might not even recognize the signs of preeclampsia until they get into danger zones and end up referring them to the teaching hospitals or regional hospitals where mortality usually happens. So it gives us where we should be targeting in terms of our intervention. Next slide, please. Then we go further to look at the type of anticonvulsant that were used. So on this, we get here about 78% of the facilities that really use anticonvulsant end up being magnesium sulfate, which is the drug of choice. However, we have 18% using that magnesium sulfate and diazepam, the combination. But there's 4%, which is significant, using only diazepam. So if we want to improve the quality of care, we should be targeting issues to do with availability, the skill, and all that around this important medication, which is for the prevention of eclamptic fit. Next slide, please. So with this, I will go on to look at, first, let's look at the national, some key issues for national response. And here I'll say that we really have to look at building capacity at the lower facilities. And these are places where majority of the time, most of our cases come. Capacity here should start with a bit of education. And that's where I'm happy Action Pre-Eclampsia is starting to let people understand that it's not about pain, or the severity doesn't depend on what you feel. We should be able to have clear ways of identifying the danger signs to be able to do the early diagnosis. Another way could be having clear algorithms with which we'll be able to detect or guide people in lower setting to be able to make the early diagnosis of pre-eclampsia and also route them for care. Then the last aspect, to be able to provide the necessary supplies, make sure that we have the availability of anticonvulsant, though many suppliers might not be willing to provide it because it's not quite lucrative in terms of cost. It's a strategic commodity, and we should make sure we have it all available. We say all facilities should also be able to have anticonvulsant commodity security, which is a very important thing, and there are already strategies in place to make sure that we include this drug in most our supply chain management and charge all managers to be able to have it available at all times. Another area we're talking about the high level facilities to be able to have the capacity to attend to complications that emanate or that are referred there. Here we're looking at how to have a high dependency unit, intensive care unit with ventilators and people skilled. At least we should be moving towards an area where we have obstetric intensivists that will be managing most of these conditions. Other than that, then we'll be having situations where people get to the big facilities only to be converted into numbers, as had been the case. Next slide, please. So as recommendation, we're saying that huge investments are needed to be able in the area of pre-eclampsia, eclampsia. All these facilities at the lower level need to be stocked appropriately. People need to have the needed skill and knowledge to manage them at that level before they become problem, because we understand that prevention is the first step. Again, this will require multi-sectoral collaboration. Here we're looking at public, private, we're looking at different agencies within the country coming together to make sure that majority of the people, everybody understand what preeclampsia is and what it takes to be able to really handle it. There is a gap, there's a need for knowledge. We need local knowledge which can be gotten from research. We should understand how our local women comport or respond when they have certain conditions or when they are faced with preeclampsia. So there's a huge area where we think that research might be able to help in providing us the required knowledge that will help us to be able to put in strategies that will be geared towards improving the care for our women. Then we're talking about resources. These resources need to be ring-fenced because there are quite a number of competing issues within our health sector. And if we do not ring-fence resources geared towards preeclampsia and act purposefully to address it, will end up running from one cause to hemorrhage to the other, and at the end, most of the major things that need to be done to deal with preeclampsia will never be done. So we're looking at how to target purposefully resources for this area. Next. So in conclusion, I'll say preeclampsia, eclampsia is the leading cause of direct obstetric mortality in this country as we speak now. There are huge challenges with the use of anticonvulsant. Here I'm talking about magnesium sulfate across many parts of our country. Then we say early detection and management is the key, and we should put every effort in place to make sure we're able to do that. Then the last but not the least, to say together, let us work to improve the national response for pre-eclampsia, eclampsia. Thank you.
Thank you very much, Dr. Fofie, for that insightful presentation. Indeed, it's disturbing to know that initially it used to be PPH that was the leading cause, but now it has moved to pre-eclampsia. We must be doing something wrongly. To know that pre-eclampsia is now the leading cause of maternal death is really alarming. And you have delightfully shared some recommendations. We hope that this can be put into practice to help us avert the dangers and the maternal mortalities and infant mortality associated with pre-eclampsia. Thank you very much once again, Dr. Fofie. Next, we want to have a panel discussion. Our team of experts are ready here to discuss some of these mind-boggling questions that we have displayed on the board. So on the screen, sorry. If our experts are ready, would like to engage you in these questions. We'll call on our chairperson, Dr. Mary Coleman, to lead this section for us. And so, Dr. Mary, the floor is yours.
Thank you very much, Dr. Funjo. I once again want to thank the panelists for agreeing to take us through this. These are questions that have been put together for us to think through the issues of quality of care. And I would like to probably start with Dr. Sofenyo. You see patients on a daily basis. They come through with various issues, and specifically for our purpose this evening, hypertensive disorders in pregnancy. And I just want you to tell us, what are the challenges involved communicating this condition to your patients? How are you able to get them to understand what this condition is and how you can walk them through care to be able to get good outcomes?
Thank you very much, Mary, for the question. And I must say that even as I'm answering you now, I'm having to rewrite my script because of the mind-boggling statistics that had come to the 2020 from the 2020 survey. It's so disturbing. It's so disturbing. On daily basis, for those of us who work in regional hospitals and then teaching hospitals, it's a daily affair that pregnant women come on daily basis with their blood pressures high. And the question is, in our various vernaculars, do we have the appropriate word? For those of you who are experts in vernaculars, you can help us in this respect. I know Koiwah was trying to do some work on the appropriate communication when you are talking about hypertension. In English, we say hypertension. But what is the appropriate word? A woman who may not have a high education as the rest of we will have. For me, that's the first challenge. That do we even have the appropriate vernaculars in our various languages to communicate to them? Let alone talking about the other complications of hypertension, the other complications of pre-eclampsia. Because as we all know, pre-eclampsia is not hypertension alone. Hypertension, of course, is a major part, but there are other pathological conditions that are going on in the woman. Her liver may be undergoing some stress, her kidneys. In fact, it is said that every part of the body is affected by this disease condition. How do we communicate all these things to our patients? You know, that the system is a multi-systemic disease. These are the challenges for me. These are some of the challenges that are involved when we want to talk about this disease. If we want to say that, oh, there is now urine in your, or maybe protein in your urine, how do we communicate this protein in your urine, and so on and so forth? And for me, these are the things that, as we advance in this effort, these are some of the things that we should be talking about. One other thing is being able to encourage our patients, once we are pregnant, to encourage our patients to also begin to check their own blood pressures in the house, because now we have digital machines. For those women who are a bit educated, we have digital machines that can help them check their own blood pressure and even feedback to the doctors. So this will be my initial remarks. Now, even what are the vernacular communications available for us to communicate this condition and the other complications that are going on in the woman, like the kidney having the impact, the liver, the other organs of the body. How do we communicate this? It's always been a challenge. It's always been a challenge. Thank you.
Thank you very much, Dr. Sofenyo. I don't know, Dr. Bayo, if you want to make any contribution from where you sit, because Dr. Sofenyo makes very important points. How to get the patient to understand what you are talking about. And often for us in the medical care, especially in obstetrics, the language, the gaps are there, you know, for them to understand and be part of the process, like taking their blood pressures. Okay, so if we'll go back to the panelists, I don't know if Dr. Miriam wants to share her experience with us. Is she with us? In the Netherlands, how have you been able to do this? How do you do it so that we can learn from you? How do you communicate this condition to your patients? Yeah, I wanted us to get the experience from the context where they're doing well on this, because it really starts with your ability to communicate to your patients so that you can carry them along in the care. Klaasje, are you able to share with us any insights from the Dutch experience?
Thank
Okay,
you.
pleasure.
I'm there. Of course, I am not an obstetrician. I'm a family physician, but I had some experience also in a few years in obstetrics in the Netherlands. I think what's the key issues that are being raised so far is about how to communicate to lower educated women. And yeah, I think as a medical doctor, we in general should find a way to use words that are appropriate for certain populations. And I could give an example about the Dutch situation, but I think if there is people who's having any experiences with the Ghanaian situation, it would be interesting to hear them as well. What I personally always do is to try to make it very easy. Sometimes draw on a piece of paper what the influence is of HTP, what it does on the body as a whole. Just to, yeah, as a quick example.
So using images, what the people can relate to.
Yeah. For example.
Again, I'll need my moderators to help me with who is on and who is not, but to quickly take a go at it, I think we'll ask our panelists from Koiwah Teaching Hospital to tell us the challenges they have in getting the complication going. Dr. Osman, I've seen the obstetric clinics in Koiwah. It can be huge, and even if you are showing videos, how do you practically do this, and what are the challenges? Because they need to understand the condition they have. And maybe I will add the third question so that you can bring your perspective so we can wrap the session up quickly. What are the challenges, but also what is really the role of shared decision making for better care in taking care of these women? You know, how do you bring them along to make sure that eventually what they get is they've inputted into what the care they get? Does he need to be unmuted? Great. I'm seeing Dr. Bayo now. But
yeah, I'm here.
Okay. Does it mean Dr. Osman is not on for us? Dr. Osman, please go ahead.
I prefer Dr. Bayo to go first because he is the obstetrician, so he may share more light than I do.
Okay, Dr. Bayo.
All right, thank you very much. I associate myself with the earlier comment by Dr. Sofenyo on the use of our local languages, because I did a qualitative study in Koiwah and realized that because there is no clear Ghanaian language for pre-eclampsia, it's very difficult for the women understanding exactly what you mean. In fact, even understanding the word hypertension is a challenge, because when you say in P Mojabroso, people think HB is too high, or is it blood pressure that's actually too high? You know, so the communication, definitely there's a gap there. And also the numbers makes it very difficult. Later we understood from one of our work that a lot of patients actually get to understand the condition way after they have gone home. And sometimes when they are in the postnatal clinic or lying in the postnatal ward, and that's where sometimes the pressure is down. And when they ask the doctor, what has been happening to me? Then the doctors are able to explain better. So in the heat of things, when patients have come in, very little communication is actually taking place, which is bad. And we are encouraging people to really try and talk to people. Now, when you come to the shared decision making, I say there are obvious benefits to the clinician, as well as it is to the mother, if you involve the women in the decision-making process. And a lot of us lose from this dividend of involving the women. the clinician is faced with very difficult decisions. When do I end this pregnancy? How do I communicate the outcomes of the pregnancy to the woman? If I'm having to deliver you at 29 weeks, what justification am I giving you? What kind of assurance can I give you that your baby will make it or cannot make it at the neonatal intensive care? If only we got the women involved in the decision making and they understood that, look, okay, you have to now balance between my baby and I. And at this point, we may not have both. Or if we are fortunate, we may end up having both. But on this call, let's place my life first and hope that my baby comes through or pulls through this struggle. If we did that, sometimes the patient will even help us so much in the decision making. But when you don't involve them, then you, the clinician, is now faced with, okay, now you are gambling a decision. You are not sure what the outcome is going to be. Mother survives. The next day they ask you, why I thought you have to take out my baby at this tender gestational age? And then it becomes difficult to explain at that time because they are out of the woods. They don't understand exactly what happened. And they find it difficult to appreciate what went into your thinking process at the time. So I think going forward, imaging will be helpful. If you have a lot of these diagrams showing the liver, what is happening when you are in HELP syndrome, showing what could happen if somebody is having an eclamptic fit, some brain images showing what could happen if you have a stroke, and then explain what the potential complications are to the woman quickly in the emergency unit or the clinic, then they can contribute to the discussion. And I think the images will help. Secondly, those who are good in the local languages, we should think of coining unique words that we can communicate to the women that mean exactly what we mean when we are talking about pre-eclampsia, when we are talking about eclampsia, or just gestational hypertension, or even chronic hypertension. And I think this will be helpful going forward. Thank you.
Thank you very much. Dr. Osman, I know you are a pediatrician, but we're talking about the role of shared decision making. Any perspective from your angle when the women have had the complications and it has affected their babies? They survive, they come to NICU, you see them. What do you think that we should do with respect to shared decision making to make sure mothers are in better position to be able to handle the outcomes of HDP?
So I hope you can hear me. I don't know that.
Yes, please, we can. Thank you.
Yeah, so when they deliver early due to preeclampsia, most of the time they are very anxious as to what will be the state of the child. So even though we are concerned about the child, we have to explain to them what might have happened to them that has led to them giving birth early. But the key thing is you always have to give them the assurance that everything possible will be done to help the baby survive, because that is the number one thing that they want to know. And helping them go through the process and reassuring them can help them so that they don't become too anxious. At some point, for some mothers, we have to sometimes get clinical psychologists involved to get them go through the process, especially those occasionally you find some that maybe they've tried several times to conceive and they've lost, and now they've been able to get one through, but they were not able to carry it to term. And so from our point, we always have to give them the assurance from the baby standpoint that we'll do everything possible to help the baby to make the baby survive.
Okay, thank you very much. So you lead us towards the angle we want to go, the psychological impact on the mother. And to wrap up the session, I'll just take quick perspectives from Madam Beatrice Dumfour-Williams, who is in Koiwah. Have you had to deal with some of these women? And what is your perspective of the understanding of the condition that they've had, and the situation in which they find themselves in? Then when you are done, we will take perspective from the USA on the psychological effect from Dr. Arku, and then we'll wrap up this session. Thank you.
I don't see Dr. Beatrice yet, but I do see Salim Wangabi, clinical psychologist at the Greater Accra Regional Hospital, who has also lots of experience in communication.
Okay, so Salim, if you can share your perspectives with us quickly.
Hello, good evening. Can you hear me?
Yes, we can. Thank you.
Yes. So it's been a very insightful discussion, hearing Dr. Srofenyo, Dr. Titus, Dr. Fofie speak about pre-eclampsia and what happens. So my perspective is going to be that experiential period that a woman will have to go through, from the period of receiving that bad news of having pre-eclampsia through its management, delivery if we are all lucky, or the other bad news of when they lose the baby. What happens in that moment? I know for most health professionals, the difficulty is not with telling patients what is happening with them, but also have to deal with the emotional aspect where they'll have to break down and may not even want to hear completely what is happening with them. So as part of even informing patients, there's that angle of whether they are emotionally ready to hear you out. So I think I've had cases where a mother may have lost a baby due to pre-eclampsia and it's on the ward. Then when you go to have psychotherapy or grief therapy, the first question will be, how long have you been here and what has happened? And interestingly, as part of the stages of grief, this mother might be in denial and she'll tell you, I don't know anything. I have not been told anything. And sometimes, to my surprise, the doctor may have informed her of what happened. And then she has just shut out from all that information and would not want to accept it. So how do mothers go through this traumatic episode? And what are the supports we are supposed to give them to ensure that their well-being is not left to just the physical, but a holistic care? So it's very important that even in disclosing their diagnosis of pre-eclampsia, the emotional state of these mothers or these pregnant women is assessed. And when the assessment is given, what are the supports available for them? I think it was Dr. Osman who just finished saying that they do refer to the clinical psychologist. That is when it is detected. Because for some mothers also, the tendency to want to be a very strong woman and strong mom would never show any signs of emotions during consultation. They come into the consulting room and when you ask them, how are you? I'm fine. Are you sleeping well? Yes. And they just want a live baby. So they keep suppressing this emotional part until it becomes overwhelming. And this can go a long way to also affect the adherence to medication and even treatment. End with my submission. If there's anything later, it will come up. Thank you.
All right, thank you very much. Thank you. This has been very insightful. We are going to go into the various rooms to have more discussion. I believe that we'll delve a bit more deeper into some of the issues that you have already touched on. I think at this point, I'll hand over to the moderators whilst we get ready to have the interlude. Thank you very much.
Thank you very much, Madam Chair, and our esteemed team of panelists. You've dissected these questions very well, and you've preferred some recommendations. Hopefully, this will help. You've talked about using visual aids. You've talked about shared decision-making involving mothers and their husbands, and also looking at coining unique words that could probably explain the condition better to the patients. Would like to take questions from the audience. If you have any questions, you can raise your hand or you can write in the chat section and we'll let our panelists address your question.
So Linda, I can see Dr. Valotu raised her hand.
All right. Yes, ma'am.
Yeah, thank you very much. And thank you to everyone. Interesting, very important discussions. I just want to make a comment on the last bit about the psychosocial support. You know, we did some work looking at mothers who had ever had stillbirth and what they went through. And there is this culture that you don't have to cry or mourn for more than 2 weeks. Otherwise, your next pregnancy will be delayed or you will not have another one again. So as we look at this, I think that it's important to also look at some of the practices that take place and how we can include this. Another comment is the importance of having the male involvement is key if we are to make a difference. And I think that from Koiwah's submission in the video, you will realize that the husband was very supportive, and we need that as well. Thank you very much.
Thank you very much, Dr. Vanotu. Indeed, those are very insightful recommendations. I see that Cecilia Dongo, your hand is up. Kindly unmute yourself and ask your question. It could be a suggestion. Please go ahead. I see Christoph's hand also up. You could also unmute yourself and ask your question.
Thank you. My question goes to the doctors. If a woman, most of these cases are being referred to the higher hospitals, say the regional hospitals or the district hospitals, but in the facility and have been cared for. What other information, vital information that is needed to be sent back to the CHIP compound or the health center where this woman is coming from, so that continuation of care can be done and further education? Because most of them, when they come back, and I happen to liaise with colleague midwives who are working in the peripheries, and it's just that they come back and the next time they see them is another pregnancy. They don't even know when they were discharged, they don't know the care they went through and what happened, and there's no document following them back or even giving back to the facility that send the referral for the continuation of care. So I want to know from our doctors, cases like that, how best can we handle this so that the care will be circulated all around with the facilities, the health workers, and the clients or the mothers themselves, so that subsequent preparation and even more knowledge about the condition will be spread at the periphery. Thank you.
Thank you, Cecilia. I'll respectfully ask Dr. Bayo to address Cecilia's question for us. If Dr. Bayo is here, kindly.
I'm here.
Thank you.
So it's a very valid point from Cecilia. And considering that some of the complications of preeclampsia have long-term consequences, especially these women, some of them develop acute kidney injury. We need to know what their renal status will be in the ensuing months. And some of them may need some time to recover fully before the next pregnancy. I admit that our feedback mechanism in referrals is very dysfunctional as of now. If you take the standard referral form, there is a section below which is supposed to be a feedback form that the receiving physician is supposed to fill and give back to the woman or whoever it is to bring back to the facility they came from. Unfortunately, that is not happening so much. And those in the CHIP centers are those who are with the woman in the community and can be able to tell the woman's condition is better for her to come back, better for her to come back. I think that it is important that we do this cross referrals, let me put it that way, or sending of feedback, and we would have to work on it. So I'm hoping that now that we are going digital with the e-health across the country, and if the entire system is made electronic, then this will become so easy, because once you also log in, you can see whatever has happened to the woman, wherever the woman was managed. Thank you.
Thank you very much, Dr. Bayo. Gina, I see your hand is up. You have a question. Please unmute yourself and go ahead.
If not, I know Benson has collected a few comments and questions from the chat, so maybe we can introduce these as well.
Okay, Benson,
right,
please, the floor is yours.
All right, thank you very much. So we've received interesting comments here. I want to read one from Koiwah Japan, who is saying that awareness creation through education is key. especially in our culture where we attribute the signs as a determinant of sex of baby. So she is saying that once we start seeing the clinical features of hypertension in pregnancy, we attribute that the person is going to give birth to a boy. That's interesting. Thank you for sharing.